it's good morning somewhere. So good afternoon and good morning, and so nice to have you in this webinar, this meeting on self-care. Of course, with the COVID-19, it has become even more important to ensure that we can increase the knowledge and the utilization of self-care as much as possible, because of access to many of the healthcare facilities has been limited, one by fear of many people to go to healthcare facilities, and also by the overwhelming rush of patients with COVID who are seeking help, or people who are suspecting. So between the fear and the rush of patients and actually the resources all going to COVID in this early peak of the pandemic, makes self-care more or less, it's more important than it has ever been. All going to COVID in this. I find my, is it okay? Can you hear me, Dr. Professor Salman? You hear me well? Because I heard my voice coming late. I can't hear you. Please.
Carry on, sorry.
Okay, it's okay. Okay, thank you so much. So we will start by two panelists, by actually three panelists who are going to set the scene. We'll have one presentation from WHO run by Dr. Manjulaa Narasimham from WHO Geneva, and by Dr. Karima Golbosri from the Eastern Mediterranean Regional Office of WHO. They will give us one presentation and a short video on self-care. They've been working on this for a long time, both of them, and started actually to roll it out in the Eastern Mediterranean region from early last year. They've rolled it out at the regional level and also at national level in a number of countries. And many countries are now adopting the approach of self-care. This will be followed by Dr. Austen, El-Osta from Imperial College London, who's also specialized in self-care and who's been working for a long time with Imperial College and developing the concept as well. After they finish, we'll give a very maybe brief points of what they have said, a brief summary, to be followed by the discussions from the panelists, Dr. David Weber, Professor Tawfik Khoja, and Professor Salman Rawaf. So let me now start by my colleague, Dr. Manjulaa Narasimham from WHO Geneva. Manjulaa, you have the floor, please. You can start.
Thank you so much, Maha, and thanks everyone. Thanks, colleagues. This is great to be able to speak today on self-care interventions. It's really very timely, because this time last year is when we published the first consolidated living guideline from WHO on self-care interventions for health. So we're actually celebrating an anniversary here at WHO and sharing messages with our partners around issues related to self-care and self-care interventions. And lovely to have Maha, our colleague Maha, chairing this, and David and Austen, with whom we've been in discussion for the development of the guideline as well. We have a short film today to share, and I'm going to try and share my screen and show this short film before actually making a brief presentation of the overview of the guideline and handing it over to Karima, our colleague from the EMRO office, for, as Maha said, a more in-depth view of some of the interventions that they're already being rolled out in the region. So let's start with seeing if this works.
Manjulaa, you need to open your video as well, I think.
Just trying to, here we go.
Fine, that's fine. We can see it now. Please.
Okay.
Yes, please go ahead.
Ensuring the right to health for all requires a fundamental transformation in our health systems. The World Health Organization recommends self-care interventions for every country and economic setting. as a critical path to primary healthcare and as a way to reach universal health coverage.
Devices, digital health, drugs, and diagnostics continue to evolve so rapidly that people have new ways of accessing their healthcare.
I look at self-care as a revolutionary approach, especially that it brings the sense of taking services closer to the community.
There is now a shift in the way we are beginning to manage health.
Self-care does not replace the healthcare system. It is the ability of individuals, families, and communities to promote and maintain health, prevent disease, and cope with illness with or without the support of a healthcare provider. Self-care shifts the focus away from a responsive approach towards a more integrated approach, which strengthens links between primary healthcare and communities and considers the holistic needs of a person. Self-care supports key principles of human rights and gender equality. In 2019, the WHO published guidelines on self-care interventions for health, with a focus for this volume on sexual and reproductive health and rights.
Là, le self-care est arrivé. Pour nous, franchement, et les travailleurs dans le terrain, c'est une bouffée d'oxygène. C'est-à-dire qu'on va répondre aux besoins spécifiques de cette population.
The guidelines address different areas that empower individuals to prevent, test for, and treat disease themselves in a safe and supportive environment. This includes supportive laws and policies, health financing, regulated quality products and interventions, and education.
As much as communicating with the community is concerned, we use the language they can understand. And then we try and have a face they can relate with, as opposed to the white jacket and scrubs.
When there are effective, integrated health systems and supportive legal frameworks, self-care can offer new possibilities.
Muchos ginecólogos, psicólogas, parteras, enfermeras se juntaron a tener una relación médico-paciente más horizontal y no salir un poco del modelo hegemónico y darle herramientas a la mujer para que ella pudiera tomar sus propias decisiones.
The self-care work is the first line of defense on all health-related issues.
When individuals are given the opportunity to become active agents in their health, not merely passive recipients of health services, their health outcomes improve. Self-care can pave the way towards universal health coverage and a world where everyone is able to realize their right to health.
Thank you. I hope you were able to see that. It wasn't, did that come out clearly?
Wonderful. It was wonderful. Please go ahead.
Great. Okay.
So what is COVID-19?
I have what is this? Something else has started. I'm sorry.
Coronavirus disease.
I think it was, okay. There we go. Okay. So what I will just present briefly, as I was asked to just give an overview of the guideline itself, just maybe show a few slides and share the overview from WHO's perspective on how we're seeing the health systems and people-centered approach and the linkages between that. So let me see if I can just share this. Can you see my screen?
Yes, we can.
There we go. Okay. So just so briefly to get the WHO terminology and definition for self-care is the abilities of individual families and communities promote health, prevent disease, maintain health, and to cope with illness and disability with or without the support of healthcare providers. And we do appreciate that this language can be quite different depending on where people are coming from and the perspective that they're taking. And also it depends on the various health issues that you're working on. So if you're working on HIV self-testing, you'd be using the terminology of self-testing. If you're you're talking about self-administration of contraception or self-injection, we are using the term self-care interventions to sort of encompass all these various elements of self-care. And by interventions, we are talking about these tools that are evidence-based, that can improve health and well-being through self-care practices. So we at WHO are focusing on the self-care interventions aspect because it's the link between the health systems approach and the individual approach. And really, it's an acknowledgement also that these self-care interventions...
Manjulaa, we lost you.
So can you hear me now? Can you hear me now?
Manjulaa?
Hello?
I can hear you, Manjulaa. I think maybe...
We can't hear you.
You can hear me, Austen?
Online?
Yep, I think Maha's having connectivity issues. Manjulaa, we can hear you.
Okay, then I'll just go ahead. So I was just going to say that, these Manjulaa? Are one of the... I don't know if somebody wants to send her a message, perhaps. Should I go ahead?
Yeah, go ahead, please, go ahead.
Okay. So self-care interventions are one of the few elements that really are helpful to reach all three of WHO's triple billion targets. So those of you who may not be familiar, the new work plan and vision for WHO is to reach 1 billion more
Professor
people
Salman, can you hear me?
with
I can't
universal
hear
health
Manjulaa
coverage.
at all.
1 billion protected from health emergencies and 1 billion more people enjoying better health and well-being. And when you look at what self-care can contribute, it really helps promote for all three of these elements. And so it really becomes important. The guideline that we had was focused on sexual and reproductive health, but it is an area that's really relevant for all health issues. And it supports the goals of primary health care and also universal health coverage, as I mentioned earlier, through meeting people's needs and providing them with sort of a comprehensive integrated approach to health services across their life course. And we acknowledge that people dip in and out of healthcare as meet their needs. And self-care and self-care interventions need to address those needs and rights. It's also about addressing the broader determinants of health, because not everybody, the issue of equity is really important here, and providing not only evidence-informed policies and actions, but also quality regulated products to individuals becomes really important, and making sure that those who may not be coming into healthcare or who may be vulnerable, marginalized, criminalized, don't feel the added burden of having to do self-care or accessing self-care interventions because there's no other choice. They really need to be supported to be able to do that. And it's really about providing the autonomy, agency of people and giving them the power to make informed, evidence-based decisions about their own health, whether they are self-carers themselves or whether they're providing care for others. And the conceptual framework from WHO that informed the guideline is really about placing the people at the center. So the green circle that you see is about a people-centered approach, but within the context of key principles of human rights, gender equality, ethical considerations, a life course approach, which I just mentioned, and a holistic approach to health. So it's really an integrated approach to their health needs, rather than a sort of a siloed approach to healthcare. And we acknowledge here in this guideline that there are various places of access, that people are reaching self-care interventions beyond the formal health setting. They are picking up things over the counter at pharmacies. They're ordering things online. There's telemedicine. There's so many other approaches that are increasingly available and that people are utilizing in terms of their healthcare. And I wanted to, again, emphasize the need for that safe and supportive enabling environment. I'll say something shortly after this, but also wanted to add that the accountability of the health sector really remains critical here. It's not about placing the burden on individuals. It's really about ensuring that accountability and the links to the health sector, if that is needed, do remain. But here it's donor and governments, private sector, their accountability is also important. So it's not about rolling out one key intervention or about low-hanging fruits. It's really about making sure that the individuals are and their communities and their families are supported in the ways that that meet their needs and their rights. And so just to say a few words on the need for that safe and supportive enabling environment. And these are some of the elements of that, but protection from violence and coercion and strict stigma and discrimination, for instance, is really critical. And we can see now with people in self-isolation, the levels of violence against women and girls that are increasing. The lack of access or information or correct information is causing added anxiety and mental health issues. And so being able to provide that enabling environment so that people can make those decisions is really, really important as we move forward and for the success of some of this work. WHO has developed a communication toolkit with all of the not only the technical but communication material around the guidance. And I've just shared it with Austen actually earlier today. So I'm happy to share this with you more broadly. And I think that's it from my side. Thank you so much. I'll hand it over to Karima for perhaps a few more words around the tremendous amount of work that is actually happening in the Eastern Mediterranean region, because it was one of the first regions that not only had started the dialogue between partners, national level stakeholders around self-care interventions for sexual and reproductive health, but also did several national launches, and we're currently sort of documenting some of the tremendous work that countries themselves are doing in rolling out these interventions. Over.
Thank you very much, Manjulaa. Karima?
Thank you, Maha, for giving me the floor, and then good evening and good afternoon to our colleagues. It's a pleasure to join you for this virtual meeting. And just to complete what was said by Manjulaa, the way we promote self-care in the Eastern Mediterranean region as a very important interventions that is helping in improving health and then also well-being from both perspectives, which is health systems perspective, but also it is centered on people. And I think that was one of the strengths that is being highlighted by self-care. As it was said, we have engagement and then we have commitment for the SDGs and also for the UN Global Strategy. And we strongly believe that self-care, it is one of the interventions that is important if we want to ensure the universal coverage for sexual reproductive health. It is also very good too because it has the scope that it includes promotion, disease prevention, control, and then self-medication, and also providing care to dependent person, and then seeking also primary or secondary care when it's needed. In some settings, sometimes they made a confusion between self-care and then self-medication, and they are two different concepts, because in self-care, there is the importance of having linkages with the health providers. And then you get first the diagnosis done, and then we go to the stage of the clinical diagnosis of the problem or health issue. Then we go for prescription, and then from there, we can allow the patient or the person to go and then continue on that protocol for a certain limit of time. So there are completely two different concepts. And why it is important for our region? Because in the 22 countries we have, most of the health system, as you all know, they are built as a pyramid shape, because you go from community-based interventions, and then in some cities you have community health centers, and then you go for PHCs, primary healthcare centers, then you go for referral hospitals, and then the tertiary hospitals. So the self-care, it comes exactly in the baseline, because it is a very strong ground where you can have those strong linkages when you are providing community-based intervention, but also when you are providing primary healthcare services, and then people, they can connect. Will increase the demand, and then also the seeking care is going to be improved, and then also the relation between health system patients is stronger, and it is well appreciated and then accepted, of course, in the context of the region. So as it was said by Manjulaa, we are celebrating today the first anniversary of the consolidated guidelines. It was published last year, exactly 24th of June 2019. Our region was actively involved, because we started from the stage where we had to develop the guidelines, and we worked intensively with all the group in headquarters on how to develop those guidelines, and then zooming on the sexual reproductive health and rights. We decided after that to go back to the region and see, okay, what are the feedback of our countries? So we organized an informal consultative meeting. We involved some countries to come and to tell us, okay, what they think about the concept and then the approach. They were very much positive about it. And then also they were like, okay, we are doing it already, but we did not know, in some settings that it was called self-care. So they were like, okay, this is a very well-structured approach. And they are very happy, to adopt it, and to know that the guidelines are very much evidence-based, and they can be impactful, of course, and then measurable. The settings that we chose, they were stable, and then also emergency crisis countries, just to show, okay, what are the needs, and then how it can be implemented. And then also we emphasize on what are the prerequisites, because this concept, it should be in harmony with the existing and the different types of health system, strong or average health system, but also some of them, when they are weak, can they be connected to, because you have some prerequisites that they need to be fulfilled, health structure, service delivery, commodities, and so on. So what did we promote in EMRO, in the Eastern Mediterranean region? We have 5 interventions that we are promoting. The first one is the self-administered injection. That is about the Depo-Provera. It's DMPA, so we call it also Depo-Provera in subcutaneous. I think most of you know. We are also promoting the counter-oral contraception pills, and then also we are promoting the human papilloma self-sampling, because cervical cancer is one of the serious morbidities we are facing, and then also it's killing many of our women in this region. Family planning, the 2 I just mentioned, and then we have the home-based ovulation predictor also that we are promoting, and they help how to assess, for example, the woman can assess the fertility, and then also be able to manage when there is need of treatment. And then the last, or the 5th intervention of self-care is about the STI, it's about testing, self-testing, and this is including also HIV. So we have different countries that are taking different interventions. So we gave them the freedom to go and then start by, okay, this is the approach we agree for, and then also we go by implementing, and then we test, and then we assess, and at the end we will see the scale up stage. So this year, as I said, it was the guidelines were published last year, 2019. So the whole year we were initiating this approach in few countries in the region. And then we had a very good experience in one country where we had the minister himself, who was very engaged. And then he launched the initiative at national level. And at that setting, what was important, they had a kind of triangle where they put self-care in the middle, but then also they said we want to link it to NGO work, and then also to PHC, and then hospital. And they were all of them committed with the policy making decision. Like, he was very strong, and we had a very good result because there were conversions, but also you could see all around this approach to respond to community sexual reproductive health needs. And in April, because of course we had other activities to be implemented, but because of COVID situation, we had some delay. But at the end, we succeeded in organizing or holding 2 meetings. The first one was with the parliamentarians, because we are convinced that, you know, parliamentarians, they are very important, and then their role is very crucial in decision making and also making changes for regulation and so on. So we had special meeting for them. They were very receptive, and they were like, this is technical wise, it's very, very well structured, and that also it is feasible, realistic intervention. And they were insisting why they did not know about it, because this could have helped in this COVID response era, because it goes for before COVID, but also for COVID, and then in post-COVID. The summary of what we got, also we had another with the policymakers, and then when we summarized what I call the 6 Ps, like, we want to adopt this approach, so we have some P's that we have to consider. As I said at the beginning, this is mainly focusing on sexual reproductive health. So all of the work that has been done, they agree that you need the policymakers to be engaged, of course, and to be committed so that the approach can be implemented at country level. The second thing is to be in line and then also injected within sexual reproductive health program. Involve all the concerned partners. The more you have active partners around is going to be successful. And then when we plan, it can be injected as a continuity of the health system, but also extension of the primary healthcare service within the community. The target should be population, so it's another P. And then we have to consider the place. It can be applied wherever, like rural, mountainous areas, or urban cities. It can be everywhere. We also we agreed that whatever we're going to do for the implementation and having all these stages fulfilled, but still we have to do more work, because this is, I think, we initiated, but we are still going on. It's about the measurement and then how we can show the impact of these interventions. At this stage, and it was just last week, we had a virtual meeting with all countries that they want now to document their experiences. So far we have 5 countries who are in this stage of documenting. And once, inshallah, we will get the feedback from them, we'll be very happy to publish, disseminate, and share with you all the results. Thank you for your attention, and the floor
Thank you very
back
much.
to you, Maha.
Thank you. Thank you very much, Manjulaa and Karima. This was very useful, very much setting the scene for this, and actually takes us very smoothly to the next presenter, who's Dr. Austen El-Osta, who's the director of the Self-Care Academic Research Unit in Imperial College, and is primary care and public health research manager as well, also at Imperial College. I think Dr. Austen El-Osta has a lot of passion to the self-care issues, and would like very much interested in ensuring that the evidence-based for the importance and the implementation of self-care is happening in the right way. So without further ado, I would like to invite Dr. Austen to start his presentation, please.
Thank you, Maha, for the invitation, and I'm happy to share my screen now and to start the, I hope you can see what I see. Is that okay?
Yes.
So this is going to be a whistle-stop tour, really, about self-care generally, COVID, and effectiveness and so on, and a bit about research. So I'm going to talk about how COVID has put self-care center stage, clearly. And then we want to focus on conceptualizing self-care. We've heard from the WHO, very important conception there. We want to also look at how others see it. And some of the research priorities we think are helpful for now and later, and the future of self-care. So I think we unanimously all agree that 2020 is going to be remembered as the year of COVID. I think that's an agreement. And you know, we've been awash with adverts for face masks, sanitizer, over-the-counter medicines, lots of apps being developed now for guidelines, for support apps, or contact tracing, for example, in England and otherwise. and a huge drive to get coherent health messaging on social media. So all of these really are acts of self-care. So there's risk avoidance here, obviously wearing a mask or shielding or school closures and so on, good hygiene practices and health literacy. And these are all self-care. So we also are now all qualified and knowing exactly what flattening the curve means. So on the left here, we have the peak. So if we don't intervene, we're likely to have a lot of people infected quickly, and obviously this will have a huge impact on the health system. But if we intervene and if we shield and social distance or self-care, then we will act together to bring the curve down, and I think that's what's happening globally, which is good. So here's the policy of social distancing, risk avoidance, good hygiene practices, and so on. So you could say that it's self-care that actually flattened the curve, and it's our ability to self-care. So here's already an example of how self-care can, an absolute case for self-care for communicable diseases. We'll come back to that. So what is self-care then? Many definitions. We've heard from Manjulaa, the WHO's current description, which is very helpful. There were historical descriptions, some small, some large. This is from '98. It's what people do for themselves to establish and maintain health and to prevent and deal with illnesses. But as Manjulaa said, definitions expanded and they became more inclusive of health and well-being. And now we have further descriptions on WHO and other entities. In fact, in 2011, a review found at least 139 definitions of self-care. So defining it is nice, but perhaps we can begin to think of how to conceptualize self-care and how can we communicate what it means to individuals, common people, and otherwise. So here's one way. This was developed by David Weber, who's on the panel, president of the International Self-Care Foundation. And the 7 pillars of self-care conveniently arranges the knowledge and health literacy as one important aspect, mental well-being, physical activity, healthy eating. Risk avoidance pillar is very important, highlighted now, whether it's a seatbelt or vaccination or avoiding tobacco smoke. Good hygiene practices, not just washing hands and oral, but digital hygiene, perhaps limiting the amount of blue light we get before bedtime. And the rational use of products and services, this includes medicines, technologies, over-the-counter or otherwise, and community assets. So this is one way that we can conceptualize a mid-level description of what self-care activities look like. And there are many products and services that can promote people capacity to self-care. Mentioned over-the-counter medicines, there are gyms, there are Apple Watches and wearable technologies. Some people are very keen to engage with their personal health record, to look at their blood pressure and monitor that. Nutritionists, lifestyle medicine doctors, and of course, pharmacists. In the UK, we've had a very big healthy living pharmacy stream, which has come to an end, unfortunately. But the idea was to enhance, augment the role of the pharmacy and pharmacist to act as a hub, health and well-being hub in the community. So to bring care closer to people when they want it. So you have point of care testing, you've got all sorts of medicines and things, but also some behavioral support. So behavior is very important, and there's clearly a very intimate link between self-care and behavior change. This is the holy grail. I mean, people know that smoking is bad, but they continue to do so. Some of these people are doctors. So what is behavior change, and how can we get people to change behavior? Obviously, very important to policymakers, and nationally, internationally, a lot of thought is going into this. So behavior here, being a mix of capability, motivation, opportunity. Are we going to activate people? Are we going to incentivize them? What policies are we going to put in place to help people do the right thing? Can we use wearables and stuff to nudge people into doing the right thing? Can we incentivize someone to cycle to work, for example? Or how can we gamify health and personalize the way that health and messaging is communicated so that people can accept and understand that? And no better a place, I think, for this sort of behavior change than to use self-care to prevent or delay the appearance of chronic long-term conditions or so-called lifestyle diseases. So here we have the diabetes, type 2 diabetes, hypertension, obesity, cardiovascular disease, and so on. These are lifestyle diseases because they're more common now than ever before. And we also know the intermediate risk factors that if we control, we can limit the detrimental effect and progression of these diseases. For example, if we limit physical inactivity, unhealthy diet, tobacco use, and excessive alcohol, we can potentially, through self-care, prevent up to 93% of type 2 diabetes, 81% of heart attacks, 50% of stroke, and a third of all cancers, and reduce all-cause mortality. Now, these are papers from 2009, so we've had this knowledge for a while. Not our papers, but this is in the framework. Also, we know that self-care vastly improves quality of life. So people who think they're self-caring, when they ask, they say we love it, we feel empowered, we rely less on systems and polypharmacy. I'm an active player, etc. So quality of life is very important, and it's a bit of a soft thing to measure, but crucially very important to the individual. Just wanted to highlight this other type of construct that could be used to grapple with self-care, here in the context of resource utilization. So if someone's self-caring, an individual is empowered, they're on the left of the continuum. They don't need support, they don't need necessarily a nurse support or GP land. They can reach out with over-the-counter medicine when they need it. But if someone becomes ill or breaks a leg on a skiing trip or gets the flu, they may need support. They need analgesics, they may need some herbal medicines and so on, and then they recover and slide back. So this shows the extent that an individual requires resources to basically carry on with life. And of course, there's a spectrum. The continuum describes the ideal place, which is in the left here, and the not so ideal place. This is the hospital setting where you cannot self-care really, trauma, or exemptions of mental health otherwise. So this is another interesting way to conceptualize self-care. So the value of self-care is great. It probably has a huge return on investment potential. And health economists always want to say, you know, what is cost effective? Is a self-care intervention cost effective? So when you ask that question, you say, well, how agnostic is the intervention? If it's disease specific, self-management for diabetes, and the intervention was an app or, you know, you could get lost in the woods. I think the case is missing for the absolute case for self-care from a health economic perspective. So people are looking at other types of ROI, like social return on investment. People are happier, they're blended, you know, they feel part of a community of practice. Manjulaa mentioned that earlier, and so on. And self-care does play a key role in promoting vitality and aging. People who want to live a long and healthy life, ideally we want to maintain quality of life. And it's through self-care that they could do that. But we know already that getting people to change behavior is not easy. So it's a huge area of focus today, and a lot of governments are doing a lot of work on this space. So it's important then to embed good health-seeking behaviors from a young age, in schools or otherwise, and over the life course of the individual, for example, in the workplace and in the community and so on. Now, there are a number of formal and informal networks that engage in the self-care space to try to promote self-care. For example, in the UK, we've got the Self-Care Forum, which has the Self-Care Week initiative in every November. This is similar as well for the Self-Care in Europe Week in November. So they're very keen to hear from healthcare professionals and otherwise from communities to see what are they doing to promote self-care. And we also have the International Self-Care Foundation, which has an international gaze and looks at policy prescriptions, all sorts of things, and the self-carer. And their instrument is International Self-Care Day on the 24th of July every year. And I think the WHO released the guidelines 24th of June, so that the crescendo, it would be the International Self-Care Day, the 24th of July. I think that would have been a month launch show. I think that was perfectly timed. But the problem with self-care generally has been, it's not sexy. It's not really clinical. Clinicians don't like the term. It's a bit confused with yoga, and which is legitimate self-care, but maybe other types of self-care, like eating too much dark chocolate. But there's a lot of lack of clarity about the scope and totality of self-care. Multiple terms, we've seen that, many definitions, and multiple stakeholders and different perspectives on what that is and how in silos of activity. Many different theoretical models of frameworks, and until recently, there was no academic institution anywhere purely dedicated to the study of self-care. So in 2017, we came together at Imperial with the Self-Care Forum UK and the International Self-Care Foundation, and together we established a self-care academic research unit. the unit wanted to draw an academic boundary around self-care, to try to understand it from an academic perspective, to, in a sense, revisit what was already there, but in an academic way. The first thing we did is try to make sense of self-care in its totality. So we looked at a number of papers and frameworks, and we found 37 models or ways to conceptualize self-care, from Orange theory to the pillars and so on. We consolidated these to arrive at the self-care matrix. Here it is. It says that self-care has 4 dimensions. The first dimension is self-care activities. And you've seen these already as the pillars. They're person-centered. This is what people would do on a day-to-day basis, a lifelong commitment to these activities. And they operate at the person-centered level. The second dimension is the self-care behaviors, or, you know, what is it that the individual would do, or what is it that's being done, you know, to sustain these health-seeking behaviors. Now, this dimension operates at the person/social network or peer level. This is where, for example, nudges, wearable technologies could be used, and so on, prompts. The third dimension is the self-care context or resource utilization. We've seen this as a continuum. This is now patient-centered. You're, you know, at that level, you're not a person anymore. I mean, you're a number on a database, and it's about costs and economies of scale. So commissioners of health and well-being are very keen to push people to the left of that. But then the question is, what are you doing here? I mean, how are you sustaining these behaviors? Or which pillars of self-care are you activating and how? The fourth dimension then obviously is the system focus, wider determinants of health, fiscal policy, health policy, the weather, and so on. So all of these then are together can give us a way to grapple with the totality of self-care. And the self-care matrix then can be used as a lens to evaluate or help evaluate self-care interventions. So the second thing we did at the unit was to determine, you know, how is it that we can evaluate self-care interventions? What is it about interventions or the self-care aspect that we'd want to think about and grapple with? So we developed a simple toolkit, Succeed toolkit, which outlines or orients the stakeholder to self-care generally. If somebody were to develop a self-care intervention from scratch, what should they consider ideally ahead of the development? If someone is paying for the service, if someone's commissioning the initiative, what quality criteria ideally should they look at? For example, is there a way to look at ROI? And then we looked at the fourth aspect here is how ideally would you evaluate and report a self-care intervention? The third thing we're currently doing is trying to grapple with measuring self-care. Now, self-care is quite complicated, or quite easy actually, but you can think that many, many things can count as self-care. So we looked at the literature and we found 30-something instruments that were historically used to measure self-care. And then we mapped them against the pillars just as an exercise. And it was interesting, we saw a conversion at around 1996 that a lot of the instruments or questionnaires that were being used began to ask questions that are relevant to the, incidentally, all 7 pillars. The patient activation measure, which is now widely used, is also part of that framework. So just to quickly finishing now, so there's clearly a policy direction globally, nationally, you name it. There's a big drive to push the prevention agenda, the health and all policy approach, basically trying to get passive individuals to take more interest in their health and to become activated, essentially from poor self-care to good self-care, and more focus on upstream measures of prevention and less so on downstream interventions, because it's a little too late then. And the idea is people can live a longer, healthier, and more productive life and cost less money. And that is a nice thing to have for governments and people. The research, policy research agenda then obviously is reflecting that. The idea from cradle to grave, you know, what is being done at the country level, at the regional level, and so on, to embed health-seeking behaviors. Now, you could say social media destroys all of that because, you know, people are, you know, self-care at home, in the school, in the community, you know, are we going to get people to try to walk to work more often? And what's happening in the workplace? Workplace health is really important as always, now even more so. So we've always had the case, I suspect, for the absolute case for self-care for communicable diseases. For example, risk avoidance, that's how transmission works. And we have for a while had the case for non-communicable diseases. But there's a lot more work that needs to be done to make sure that countries and people self-care more. Just to finish off as well here, so there's a big ambition to drive care out of hospitals into primary and ideally into the community setting, because that's where people are and that's where they're happiest and most comfortable. And it's also probably more cost effective. But the self-care agenda is about all of that. But we need people to play their part as well. And we didn't talk about many things here, but already we see there's a global movement of self-care. It's been happening for a while. In fact, a revolution is taking place around the world. And as we've heard from Manjulaa and Karima and Maha, we now know that there's a global champion, WHO. So they've championed self-care, and we're very happy to work with them and to support them and to advance that agenda. Incidentally, it's on SRHR, but in the future, it could expand beyond that. So there is a major opportunity and need to promote public dialogue and understanding. And I think the invitation here is for all of us. I think that 2020 really highlighted the new decade of self-care. We had the great year of self-care last year with the publication of the guidelines and other events. And this year we have the launch of the great decade of self-care. Now, I said self-care maybe 1,000 times in the last 10 minutes, but we don't hear politicians use that word. We don't hear policymakers use it. And it is a bit heavy, but I think it's only when we hear the people we're familiar with on television begin to use that word appropriately that I think people's perspectives will shift. So that's my rundown on the self-care research aspect. Thank you.
Thank you very much, actually, Dr. Austen El-Osta. This is really very nice and gave us a very good perspective of the real work around self-care and how it's moving forward, how it is actually touching everybody's life in a way, and how it would be the way forward. I think in the future that many people, I'm not sure the clinicians will like you very much, but at least we do.
Always blame David Weber, because I borrowed a number of slides from David. So thank you, David. If the clinicians blame me, I'll signpost them to you.
No, it's really wonderful. And I very much liked that how you linked this to flattening the curve at the beginning, and then also about people feeling empowered, which is very important. You know, people who feel empowered, taking care of their own lives and their own health can help also in changing their behavior. I liked when you talked about the cost effectiveness, the return on investment, and also the return on social investment, and health-seeking behavior. Also the policy research. I think these are all very important and relevant issues. And so now I'm very happy to introduce the panelists, and really looking forward to listening to you. David, I think we're becoming more intrigued to follow up on this very interesting and very fruitful discussion. So David, it's over to you now as our first panelist.
Thank you, Dr. Maha. Thank you.
Thank you.
I will ask David a specific question in a minute or so. Professor Khoja, any question from your side to the panel now, Dr. Maha, Dr. David, you and I, and of course the speakers. Thank you so much, Professor Salman Rawaf. Actually, I received so many questions through social media, WhatsApp. Let us start with, it is clear from your presentation, Dr. Osta, about the importance of self-care in chronic illnesses and NCDs, cancer, rheumatoid, and others. But it was not clear for me, and also for the person who asked this question, that what is the role of self-care in infectious diseases and epidemic like COVID-19? Is there an proof for its effectiveness? So this is the first question. I have other questions, but let us start with this question.
I can start if you like, and I can pass on to I think not this. So basically, in terms of the case for self-care for communicable diseases and epidemics and pandemics, the theory of transmission in terms of the germ theory anyway, you need to have a contagion. So the risk avoidance pillar here, as illustrated by the 7 pillars, is key. So if you avoid the risk, you probably won't get that communicable disease. So of course, that's not a solution to the disease, but it protects itself, and that's a type of self-care. And the good hygiene pillar as well. for example, knowing when to shield or self-isolate, not necessarily for COVID. I mean, now we have COVID, but we've got, polio and other sorts of Ebola and so on. So I think we can apply this logic. So the answer isn't, self-care is not the answer for communicable diseases, but it's a really big part of the answer. That I think that's the case for it.
David, any comments on this?
Yes, if I can come in on that and very much support the points that Austen is making. The COVID pandemic has shown up the importance of self-care particularly well. So it's a good example. Austen's mentioned the hygiene aspect, obviously hand hygiene, but also respiratory hygiene is a self-care activity. The whole question of reducing your personal risks is something that's been thrown up into clear relief here, and there's a very rich discussion and education that needs to go ahead in future with helping people to understand the whole question of personal risks in this case the COVID situation. Other aspects that have been brought out by COVID are the importance of the community. Because self-care isn't just selfish care, it's about how you live and work with your family, your friends, other people in the community. And all the areas of reducing risk through physical social distancing are important. And the other aspect that's come out very clearly is that in a lockdown situation, the balance between mental well-being and physical health are really important, and that's coming into focus as well. And mental well-being is and the pursuit of that is a very important self-care activity. So I think what's been interesting about COVID and probably more generally for infectious diseases is that it really does put the spotlight on some aspects of self-care that one doesn't normally think about. Typically, self-care you think is about healthy eating or exercise or those things, but all these examples, hygiene, reducing risk, community aspect, are other aspects of self-care which are important to understand.
Thank you, David. I'll come back to you, Tawfik. There is a question from the colleagues, the audience, from Mohammed Al-Ammari. How to protect patient from or against over self-care? I mean, that overconfidence in self-care, and I'm a patient of X disease. This may, especially for people in primary care, we see that very often. How can we protect patient against overdoing the self-care process? Manjulaa? We cannot see your face, by the way.
So, well, I don't think everybody who practices self-care is a patient. I think that these are, some may be patients, some are just practicing self-care. Over practicing self-care is, I don't know, you would have to sort of measure what that over practicing means. I think having the confidence and the ability to manage your own health, it only works if you have the correct information and the correct knowledge and the ability to understand that information. And so, if this is a patient and if there is a health condition that needs to be addressed, then having that correct information would enable that person, I think, to be able to access healthcare if needed, or assess whether they can manage it on their own. But that link to health systems when you need long-term care or you need a specific health intervention remains important, which I think was noted earlier. Thank you.
David?
I think it's a very important question, but self-care does involve, as Manjulaa is saying, knowledge, health literacy. So those are important areas to work on, and it also involves self-awareness, considering one's situation, looking at oneself, body listening, and all of those things. So I think I think that realistically, the big issue is getting more people to self-care. The number of people who are actually excessively self-caring, I suspect, is vanishingly small, because it's rather hard work to do everything perfectly. But it's an important point to address.
I think the question, there are a few questions talking about digital technology, and especially our Google now, access to Google is widespread. And people at the beginning of any symptoms or issues, especially in relation to deviation from normality, I'm not talking about consulting for healthy issue. How much that actually affecting the outcome of that intervention? Especially, we have so much misinformation. We have seen on the discussion through the Technical Advisory Committee of WHO and other colleagues, we worked with them during the last 3 months. There was so much, and still more coming, misinformation about COVID, misinformation about treatment, misinformation about therapies, which is unbelievable. Anything from garlic or, breathing onion or doing this or that type of tea and coffee, etc. Austen, any idea of that access to information distorting the picture or what is expected from it about self-care?
I can try to address that. I think have a lot of online symptom checkers and other quality assured resources that people may use to check symptoms for themselves or their family and friends. And I think if these are used properly, they have great value for the self-care agenda, for triage. They could tell people when they should go to the doctor. If it's an emergency, they should just go to call an ambulance. But I think the question around misinformation is chronic. Now the mot de jour is Corona and COVID. But if it was something else, it would be about that, no doubt. So I think there have been clearly policies, whether we like them or not, to try to limit that on Twitter and otherwise. I think it begs the question that maybe we can revisit later in terms of what is right and what is wrong. I think generally speaking, for the vast majority, if you look at vaccines, for example, people not wanting to be vaccinated, in a sense, it's a right for people to not want to be vaccinated if they don't want to. But it also for non-mandatory or essential vaccines, that opens up another can of worms, as in, what is it that led you to not want to get vaccinated? What information do you know and so on. So this is a difficult topic, I think, that technology on its own cannot address. I think we need to engage with communities, but also I don't think the problem will go away because it's part of culture, I think. That's my summary of the problem.
Yeah. Maha, leading the agenda, Dr. Maha, within WHO on health protection and health promotion. I want to take this question and stretch it a little bit further. How damaging sometimes the inability of government to communicate the right messages, because we've seen not only in this region, but many other regions, government reluctant to give information, or sometimes government rush to supporting X or Y treatment. I know in many countries in the region, they are almost updating national guideline. Why do we need a national guideline? Why don't we give the fact and share it with the patient? So how do you see that element of health protection or protecting our health from COVID and promoting our health against COVID for you, Ramana?
I think protecting ourselves from COVID is very clear. And I think also Dr. Austen has alluded to this in his presentation. He showed us exactly what we need to do to protect ourselves. And this is self-care. We know that, but we know that people are not patient enough to wait for changes. They do not understand actually the value of research or the time it takes to do proper research, to come out with the right protocols for the disease. I mean, the COVID showed, especially I think social media, he played a role which is not a very good one, in my opinion, that people were there talking about the issue as if everybody became an expert all of a sudden. You mentioned Google, people looking at Google, but the lack of understanding of what COVID-19 is at the beginning caused a lot of panic. There is fear, and because of the fear, people are trying to find solutions, and governments are trying to respond to people. And then they had all these policies which probably were not well studied with their effects, or even when they were well studied, they could not continue them for a long time because of the unintended consequences of each policy. As we know, policies come, they have good consequences, but they have also some unintended consequences. Some of them are not very good. One of them, in our case with the COVID, was actually the economic problems that happen, and so many people have lost their jobs around the globe, not only in our region, and the economic problems that happen. So people, because they see this and because of the communication, they want to see something fast. People don't believe that the fastest vaccine was produced in 4 years before. So we cannot expect a vaccine to appear in few months for such a virus that with the calamity that we have now. Not because of the damage that it's doing, it just simply because the research and the testing and the animal testing or human testing that has to follow, and the approval processes and so on, people do not understand this. So I think we have the responsibility of better communicating. We need to communicate. We need to honestly and transparently explain to people why things do take time and what is exactly happened. Something is new. We don't even know what it is, how it is evolving. So all this dilemmas that came with the COVID, I think, caused a lot of panic, and people could not respond. But self-care, when it comes to COVID, it's very clear. Now at least we know. Wear your mask, have your alcohol in your pocket if you're exposed, respiratory and hygiene, washing hands frequently, and so on. Even now they're saying, the CDC is saying that surfaces are not transmitting for a long time as much as we used to. These are evolving knowledge, but we have the responsibility of ensuring that people are aware that knowledge is still evolving and that we're still working with it. So like you said, some are taking garlic, some are sniffing onions. I don't think that this is a solution. It would have been really very easy, and all of us would be sniffing onions for the rest of our lives. But unfortunately, this is not the solution, and we have to be more evidence-based and more scientific in our approach. And since the general population is not thinking evidence-based, they're thinking more safety-based, then we have the responsibility of ensuring that we provide the evidence-based and convince them of the evidence-based.
Thank you. Be alert, I think, is one of the strongest message in there is a question related to that, linked to that. I'm again extending the original question from Dr. Yahya Al-Khalidi. Is there any comprehensive application for self-care? This is to Manjulaa and David. Manjulaa?
David, go ahead.
Well, I'm sorry, I don't quite understand the application of what's meant by
any application for
an app.
Yeah,
an app. Sorry, an app.
An app.
There are something like 100,000 health apps, many of which relate to self-care, and this is one of the problems, that there are so many different apps for different aspects of self-care. And one of my hobby horses is that I think these have been developed by technology developers, wondering what they can do with the technology, rather than starting with what is the need, what is the complete need for an app covering all of self-care. So you've got apps that help with the diet or exercise or other elements, but you don't have one single app that really is pulling it all together. And I think that will be something for the future.
That's why the question was, is there any comprehensive app?
But there are too many apps for everything. We're not there yet. But in a few years' time, hopefully there will be something that captures all the elements of self-care. The sort of work that Austen is doing at the moment, looking at measurement of self-care, how do you measure some of these different aspects, is still where it's at. And I think it's worth underlining just how relatively recent the academic focus and the interest in self-care actually is. As a practice, it's been around for thousands of years, of course, but as a systematic approach, it is really very relatively recent. And I'd like to certainly to take this opportunity to say just how outstandingly good the guidelines that WHO produced last year are, and the opportunity to extend that into other areas is fantastic. Outstanding that those guidelines, and we need them for other areas too.
Yeah, Tawfik, your question, second one.
Yeah, thank you. I saw from your slides that there is a link between self-care with primary health care, but we know that self-care depends heavily or rely heavily on better information, health literacy, communication skills, and also the support from the social atmosphere of that patient. My worry is that if we take self-care as it is without coping skills and training for the people and proper education, we are going to have a problem with the real management of the patients. So I would like to have your comment in this area, because everything is good in the start, but when you go in the practice, there is barriers, there is difficulties, there is so many things facing the academic thinking. But when you come to the practical issue, there are so many problems. I remember I saw a patient communicating through Zoom with bronchial asthma, and he misunderstand the management plan for his case, and he developed an acute attack of asthma. So my comment is that we need to raise the skills of the people to accept self-care. Otherwise, we are doing harm to the people instead of doing good. What do you think about this comment?
Okay.
Answer just briefly. In the UK, we had the expert patient program, whereby people, for example, with diabetes will be invited to learn more about their diabetes, and then they will be upskilled to such an extent that they can tell other patients, people like them, how their experience was and how they got out of diet or whatever. I think the challenge, like as David said, and others would agree, there's no one-size-fits-all self-care anything. So if someone's lucky enough to be born into a family or in a village or somewhere where people just naturally have healthy lifestyle behaviors and they, you know, that becomes their life. To change behavior is very hard. That's why emphasis on school children, young people in the home, mothers, even during pregnancy is key. But in reality, we've got three segments of population. The very young people who we can try to socially engineer, but we probably will fail. We've got us, the sort of happening now people, and we've got the much more senior people who it's about more sort of ensuring quality of life. So the personalization of how self-care and behavior change aspects is so important. There's no one size fits all. So what I'm trying to say is, I think I've said it, it's a challenge.
Okay. We have a question from Dr. Saad Al-Ghabban, which is a very interesting question. It's, talking about self-isolation as part of self-care. What is the exact period? Yeah, looking for the exact period of infectivity in COVID for those who are actually self-isolating. And do we need to conduct a PCR after the 2 weeks of isolation? Any of the panel would like to answer? I mean, I'm happy to help. Manjulaa, David,
I won't speak too much because I've been speaking a lot, but basically one of the challenges we've had, and I think Dr. Maha pointed this out, is the exasperating change in speed of the guidelines being changed. Now the 2 meters have become 1 meter in the UK, 7 days, 14 days. Does that apply to workforce staff? So NHS trusts, as you know, Salman, you know, they're faffing around trying to figure out what is it that we can do? What do we tell our staff that for example, show symptoms otherwise? So this is
for those people who are infected, what's recommended that they should self-isolate for 1 week. Those people in contact or suspected, they self-isolate for 2 weeks. That is agreed internationally. Almost all the countries moving in that direction. The question is whether after 1 week the person is infective or not. If possible, we are saying that you should have a PCR, i.e. Antigen test. The result of the antigen test is not immediate. In most places you are talking about 3 days, 2 days, 3 days average. In some countries, I know we were discussing with 1 or 2 countries late last night, they're talking the result maybe 7 to 9 days because their labs, public health labs, are overwhelmed. So it's very important you have that test to make sure that the person is not infected. But all the data showing that after 7 days, most probably all of them are not infected. Okay, Tawfik, do you have any? I got list of questions. You said you have a third question.
Oh, there was a question from one of our colleagues. He said, what are the common barriers facing applying self-care in epidemics? What are the commonest barriers? Do you apply self-care? I mean, in UK, when you apply the concept of self-care, do you face any barriers which make it difficult, or you find that this applying self-care to the community is acceptable approach?
Can I pick up on that one?
Get on.
Can I pick up on that one?
Get on.
I think there are evidently a number of barriers to self-care. That they can be individual, personal issues that people have. They can be environmental issues. It's difficult to exercise if it's raining outside, or if you don't live near a park or something. So I think there are many different types of barrier that apply, and every individual has to look at the situation that they're in. I'd like to just come back on the previous point, Professor Tawfik, you made with respect to the doctor's role, the physician's role. And I think that there really is an opportunity for the physician to complement their role as an expert with their role as an enabler to help people to get the most from self-care. Nobody's going to force people to self-care, although the primary beneficiary, of course, of self-care is the person who's doing it themselves. So I don't want to get a sense that suddenly everything's over to people to look after themselves. The physician and the health system has a really important role to help people to look after themselves better. And then outcomes are improved all round, whether you're healthy or a person with a condition. But the role of the physician doesn't go away, but it changes a little bit into more of an enabler.
I think, David, this is a very valid point, which I want to stretch it, and I'll invite Professor Khoja to join. We have a few teasing questions, and I kept it to the last part of the webinar because these are interesting to get. The heat is a little bit higher. You know, a lot of people written to us saying, look, what is new? Self-care is part of primary care. You know, what are you talking about? You even not able to define it. You have over 100 definition. You know, WHO keep changing the definition from 19 82 until today, you know? So what is new? I, as a GP, was saying, you know, all my patients advise them, you know, take herbal medicine, do this, that, complementary that, take care of yourself, take aspirin if you got headache. What is new? Manjulaa?
I think that what is definitely new is the role the public health and the role of the health systems in acknowledging this. It's not something that I think happened systematically, as I think Austen mentioned earlier, and David also mentioned in earlier. I think self-care, you know, is going to continue to happen. It's been happening for millennia in every culture, every society, and that will happen, you know, it will continue to happen. The role of the health systems in the way that we understand health systems and in their acknowledgement of the sort of undervalued, underutilized potential of the individuals and the families, and that, you know, the trust that we can put in them, and the ability to provide them with, you know, quality regulated products within a safe and supportive environment. I think that is new, and the rapid rise of new technologies, of new interventions, new ways of communicating with individuals is new. And we are, you know, I think poised to try and capitalize on that so that it can really benefit individuals and communities. And I think there's a real need to place an emphasis here on equity and rights, because it's not everyone has the same access or understanding or ability to use, you know, self-care or practice self-care. And in self-isolation, you were mentioning earlier, I think that, you know, some people can do it, whether or not they have, you know, access to a garden or, you know, a big house, or if they're in a, you know, in a safe family. I think it's fine. But many are finding themselves in situations where they're not only not able to do self-care, but, you know, their rights are being violated. And I think it behooves us to make sure that as we move forward, we keep in mind, you know, is this helpful and useful for those people who are most marginalized, most criminalized, and made most vulnerable, and who need this the most. Over.
So does that mean that self-care is restricted to certain group of the population, the disadvantaged or the less wealthy? I don't want to use any other adjective, but I think rather than the wealthy people who can seek healthcare, etc.
No, that's not what I meant. I think self-care is for everyone,
okay.
And the access and availability of quality self-care interventions should be for everyone. But we know in today's world, not everyone has access to healthcare in an equitable fashion. And in order for us to be able to promote self-care and self-care interventions for everyone, we do need to pay very, very close attention to aspects of human rights and issues of gender equality and all those elements that I think many people have, you know, in this presentations have already mentioned. Because otherwise, that there are people who are already falling through the cracks, or who are not have the ability to self-care in the way that they should, and that gap will continue. We have the opportunity here to bridge those gaps, and it's our duty to do so.
I'll come to important question about teaching self-care to David in a minute, but there is a question to Austen. You mentioned expert patient as part and parcel of self-care for people who are trained by their doctor, GP, especially in chronic diseases, and they start teaching other within their peer or group of people with similar condition, how to take care of themselves. Can you describe it more? Can you give us, because people are interested to learn about the UK experience with the expert patient and how successful, how cost effective, and how does it work?
So that's a really interesting program. It was formally evaluated a couple of years ago. I think there's a really nice evaluative report looking at pretty much all of the expert patient program. And it showed a fantastic success, for example, for diabetes and otherwise. I think what's come out of it as well is the idea of activation. Again, just because you have an expert patient, or call them expert, doesn't mean that they can necessarily influence everybody they come in contact with. And David earlier alluded to the lifestyle medicine approach, whereby the doctor is as coach. So the role of the expert patient is to, I'm like you, you're on the same boat, I could do it, you can do it. It's an empowerment, activation. So in the UK, as you know now, there's this big drive, certainly in diabetes, to segment the population of diabetics into less activated, moderately activated, and highly activated individuals. Those that score high on the PAM score, the patient activation measure, usually research has shown that they respond better and quicker to treatments, and they miss less appointments. So the interventions that they're given are usually a little different because they will respond to them differently. Whereas diabetics, for example, who have a low activation score and who may not take the medicines on time or properly, or may miss an appointment with the GP, I think the priority for the diabetologist is to get the PAM score up, so that that person can then respond to treatment. So the expert patient program is nice because it was a very robustly evaluated. It is imperfect, of course, and again, in the name, the expert patient program, and also in the name, the patient activation measure. So again, it's putting the there's a patient, there's doctor-patient relationship. I just want to briefly say for the previous question at Manjulaa, absolutely, because you're highlighting the in terms of people displaced during war and immigration, you have now huge disparities, inequality in terms of economies. So people who may have done great self-care may suddenly find themselves unable to be mentally healthy, and therefore they may deteriorate, or they are displaced because they're immigrating from war-torn regions, and so on. So that's I think acknowledged already. But just to mention that there is this, not a lot of work is being done. How can we, it's a tough one, how can we promote self-care for these people with unmet needs who are vulnerable?
Okay, let me move to the other question, and I'll come to you, Professor Khoja, in a minute. Question about, sorry, can't hear me? Can you hear me?
We can hear you, Professor Salman. Please go ahead.
One of them don't hear it. Okay, Maha, thank you very much indeed. The question is that self-care is important. With that importance, why is not taught as an important lesson at primary and secondary schools? Why is not part of our education curricula? And I think this is quite legitimate questions, David, Manjulaa, Maha, in your role in health protection and promotion. Let's start with Maha.
Okay, I think it's one of the things that we have to promote. One of them is that we don't really work together as ministries of health and ministries of education. So we have to work with the education sector much more closely if you want to introduce in primary and secondary school. It's a very good idea. However, the nature of things change. So a 10-year-old child might not understand much about diabetes, but this child will understand more about physical activity. It will understand more about health, nutrition, about how to keep their eyes safe and clean, and so on. These are things that we can actually, and they do teach to children in schools, and they have exercises and they have activities around this kind of issue, especially physical activities, and nutrition has been widely adopted in many of the countries in the region now. And being promoted as part of the healthy life and well-being, especially that in this region we have a lot of diabetes, of course in adults, but it starts with childhood obesity, and we have one of the highest proportions of childhood obesity as well in many of our countries. So this is what it is doable. It just needs much more commitment. It needs to have a comprehensive approach to, we need to look at social determinants. We need to look at equity. We need to look at how we better outreach. The ideas are there, and the commitment, I think, needs to be strengthened in order to have better implementation. This is one of the things, like, we know that in Astana we talked about self-care. We know that in Alma-Ata we talked about community engagement. But these things, they're not new. You had one question, what's new? It honestly does not have to be new. And it might be a very old idea, but unfortunately we have failed to implement it. So let's look at why we have failed to implement and start to think in a completely different way. And the only way to do this is actually to bring all the forces together who are concerned about the health of the population. We know it's not just the Ministry of Health, and this is what we have to do. COVID is a very good opportunity for us to strengthen this whole of government approach, because we have seen that policies done at one level, have affected health, have affected economy, have affected other things. And I think this is our opportunity to move forward as a bigger team and not just the health team, to be able to implement these ideas.
David?
Yes, I think that's a really important question. And the elephant in the room, you might say, is that there is so much going on with respect to self-care, and so many different stakeholders that are interested in self-care. I mean, obviously, political leaders, government departments, policymakers, public health departments, health systems, doctors, nurses, etc., the health professionals, but media, education, academia, charities, technology developers. There are probably 40 or 50 different stakeholder groups, each with part of the answer and an interest in self-care, and bringing it all together and talking about the same self-care and connecting them is actually going to be one of the challenges of the next few years, because there's lots of pieces of the jigsaw that need to be put together. The other aspect is that we don't have a convenient suite of policies or programs that people can then say, I want a program to do X, a program to do Y, what's the policy for that? And that's because, again, at the stage of development we are with self-care, we're still seeing lots of ad hoc activities. Individually, some of them are very good, but they're not shared very well, and they're not being developed up into coherent programs and policies. But this is something for the future, and it's a very exciting future for us to be able to do that.
We have about 2.5 minutes. Tawfik, Professor Khoja, any question?
Yes, I think this is a comment. During my preparation for this seminar, I came with the conclusion that, as Dr. Maha said, this self-care is not a new approach in healthcare management, but it's a new terminology which I am sorry, there's a call coming up, which really I can classify it in 3 levels of self-care. The first one, which is lifestyle changes and maintenance of a healthy life. The other one is self-care for minor illnesses. The third one is self-care for chronic and long-standing illnesses. And for each one of them, if we take the lifestyle changes, as a smoking, stopping smoking, healthy life, healthy diet, and for self-care for minor illnesses like first aid, over-the-counter medication, and for chronic illnesses is counseling and proper management of the disease by the patient with the support from the healthcare team. So I can put the self-care in 3 categories, but the physician or the healthcare provider should choose which is appropriate for each patient. How can he interfere, or she can interfere with each person, with each community, with each society? So this is what I came after from it.
Thank you, brother. Thank you. We are in the dying minute, and let me, at the end, thank you in particular, Professor Khoja. My thanks on behalf of the Arab Public Association to Dr. Maha, to Dr. Manjulaa, to Dr. Karima, to Dr. Austen, and in particular to David for joining us at such short notice. We are extremely grateful. Our weekly seminar will continue in the last few seconds. Our next session, we have two prominent speakers on primary care, followed that then on the 8th of July, COVID treatment, then COVID and mental health, and I will circulate the list to the member of the association. Thank you very much, and have a good day or whatever left from the day, and see you next week.
Thank you very much.
Thank you.
Bye-bye.
Thank you. Bye-bye.
Thank you all.
Thank you. Bye.
Thank you, Karima. Bye-bye.
Pleasure. Bye. Take care. Bye.
All the best.
Tawfik.